Anyway, this is a problem that we will all see. It's a very common injury to have, is an ankle sprain, and some people would say actually there is no such thing as a simple ankle sprain. And if you look in the literature, if you ask people if they've got residual symptoms, somewhere between 20 and almost 80% of people will say that they have some sort of problem. This is a big study done in Holland. This is Van Dijk's group, and looking at almost 600 patients after 6 years, and they found 40% of patients still had residual symptoms, and this was irrespective of the grade of sprain that they had. 6% of these patients couldn't go back to work, and 15% of these patients could go back to work but had limitations at work. So this is a big problem. This is something you will all commonly see. What do they complain of? Well, residual swelling, pain, instability, or a feeling of instability, and often stiffness as well. So how do I investigate an unresolved ankle sprain? Well, I'd say the most important thing, first of all, is to talk to your patient and to put hands on your patient, okay? Because that will determine what the most appropriate subsequent investigation and treatment is. You will get a very good idea from where their site of pain is, what causes their pain, and how long the pain lasts for, where the swelling is, etc., as to what the underlying pathology is. A plain X-ray is a very good way, a very good screening test, and we would all get that, although it is surprising how many are sent to us without X-rays. And then it depends on what your local expertise is and what you feel the underlying pathology is. If you feel it's an underlying bony pathology, then a CT, and possibly a CT arthrogram, if you have that available, would be very useful. MRI scan generally is my gold standard. If I can get an arthrogram with that as well, all well and good. I think selected anaesthetic injections around the foot and ankle are very useful. Certainly for your impingement syndromes at the front or the back, local anaesthetic into the area of suspected impingement. If it resolves the symptoms, then you've pretty well got your diagnosis. And also having a look inside the ankle joint. I rarely do this without a preoperative MRI scan, but if you haven't got a decent MRI scanner, then an arthroscopy can be a very good way of having a look. So what causes are there? Well, the list is endless, and this talk could go on for 40 minutes if I go into a lot of detail. But I think if you look at specific areas, this is a good way of trying to eliminate most of the common causes. So the first thing really is occult fractures. What do we mean? Well, these are the ones that are often missed on initial presentation, missed in the emergency department. So here you can see, for instance, there is an anterior calcaneal process fracture. Again, inexperienced people looking at radiographs will often miss these. I think a very important clinical sign is the inability to weight bear. If you get somebody with what is essentially a sprained ankle and a normal looking X-ray and they can't weight bear, I would urge you to get further imaging of that patient. Okay, it is surprising how often you will pick up an occult fracture, and the one that I'm commonly seeing these days is the undisplaced posterior malleolar fracture. Okay, so shows up quite nicely on an MRI scan. Other common ones, lateral talar process, that's been covered previously. Cuboid fractures, again been covered previously. Your base of fifth metatarsal, and your impingement type syndromes or your fractured os trigonum at the back of the ankle. All things to consider. What else can cause residual pain? Well, articular cartilage injury, and usually the patient will point to the level of their ankle. This is where my pain is, and it's usually on the medial side of the ankle as well. How or why does this happen? Well, this happens because of the tilt of the talus and the impaction of the talar dome. So you often get articular cartilage injuries at those areas. It can happen on the tibial plafond, it can happen on the talar dome, or the medial malleolus and the medial side of the talus, and that's a so-called kissing lesion. It can also happen in the subtalar joint if you've got a subtalar dislocation or a subtalar sprain rather than an ankle sprain. So what sort of things are we looking at? Well, first of all, on the left there you can see that's a purely cartilaginous injury. Okay, you look inside the ankle joint, initially it looks normal, but if you get your probe and probe around, suddenly it'll fall into the cartilage crack. If it's unstable and it's loose, it's got to come out, otherwise it'll remain symptomatic. You can also get the semi-detached lesions or the partly attached acute osteochondral fractures, as you can see in the middle there. They can be pinned back with either bioresorbable screws or headless screws if there's a big bony fragment with it. If there's not a bony fragment, it's got to come out. And you can get the fully detached lesions, as you can see there on the right-hand side. Again, there's not a lot you can do about them unless you can actually find the fragment and pin it back. But in the chronic situation, sometimes that's not possible. A lot of these lesions are asymptomatic, and if you scan a lot of ankles, you'll see them. So you only treat the symptomatic ones. If they are less than 1 centimetre in diameter, then they generally do very well treated arthroscopically. You can curette them, you can drill them, you can microfracture them. They're all suitable techniques and they all work very well. Microfracture and curettage probably are slightly superior according to the literature. If, however, you've got a big lesion, more than 1.5 centimetres in area, then the likelihood of curing that with curettage or with microfracture goes down to about 50%. But I think it's still a worthwhile procedure doing because it will help 50% of your patients. Once you're getting into the area of big lesions, then you may need to be considering more tertiary procedures such as osteochondral grafting or ACI, which is the autologous chondrocyte implantation. But these are much more invasive techniques and they take a lot longer to get over, although the results are generally good with about a 90% improvement in the patients. What about tendon abnormalities? Well, actually we've already had a very good talk on tendon abnormalities today. The ones we commonly see are obviously your peroneal tendons. These can be a pure tenosynovitis, and as we saw, you can sometimes get a very tight band, which is actually the inferior peroneal retinaculum, and you get a stenosing tenovaginitis. And if you release that tight band just beyond the distal fibula, then you can get good resolution of symptoms. Otherwise, synovectomy can be a very effective procedure as well. If you have a split in the tendons, again, we've seen that you can either directly repair the tendons or sometimes do a side-to-side tenodesis. And don't forget about the subluxation tendon, the subluxating or dislocating tendons. Again, if you don't look for it, you won't find it. Okay. The natural history of peroneal tendon problems is they tend to grumble on. So they're the ones that do tend to need surgical treatment. So if you look here, you can see that there's a tear in the peroneus longus. You can see that on the MRI scan. It actually looks as if there's 3 tendons there rather than 2 tendons. So in general, if it's a partial tear, then you can tubularize the tendon and you can repair the tendon, and they do very well. If it's split, then generally I will excise one part of the split tendon and then tubularize the remainder of it. Which bit do you take out? I tend to take out the bit that is either the less damaged or the one that is still attached to the muscle. Okay, so if you've got 2 bits that look the same, take out the one that's not actually attached to the muscle. And if it's severely tendinotic or heavily torn, then a tenodesis to the other tendon can be a very effective method of treatment. So here you can see the superior peroneal retinaculum's being opened. This is an incompetent superior peroneal retinaculum. You can see the fibula here, and this is the bare area. The tendons dislocate, they lie on the fibula, and it doesn't allow the superior peroneal retinaculum to stick back down again. So you often get this big baggy area over the fibula, and you can see it there. Okay, how do I treat this? Well, I'll do a fibular groove deepening so that the tendons sit quite nicely behind the fibula. I will then burr the bare area and put a couple of suture anchors into it right at the edge of the bare area, suture the peroneal retinaculum back down, and then repair the rest of the superior peroneal retinaculum. And again, they do very well. Looking more at the soft tissue and bony impingement problems that you can have. These can be things like the so-called meniscoid lesion, can be simple synovitis or arthropfibrosis in a joint. Now these are the ones that sometimes an MRI scan will not help you with. Okay, so if you do have somebody who's got symptoms in their ankle joint from their history and their examination, and they've got a normal MRI scan, then put in a bit of local anaesthetic into the joint and seeing if it resolves their symptoms can often give you a good guide as to whether or not they will respond to an arthroscopic debridement. These are the ones that don't have talar dome lesions, but they have symptomatic ankles. What is a meniscoid lesion? Well, it's really scarring of the anterior inferior tibiofibular ligament. It's also called Bassett's ligament or Woolen's ligament. But essentially it's a band-like tissue that you will get in the ankle joint that rubs on the lateral talar dome. And these are very amenable to arthroscopic debridement. I simply cut it under direct vision with a knife and then use a synovector to remove the remainder of the meniscoid lesion. So here you can see it rubbing against the lateral talar dome. And again, that can be very, very effective treatment. Soft tissue impingement, here you can see a normal ankle on the left. I'm sorry, it doesn't project particularly well, but if you compare that to a horribly scarred and synovitic ankle, it's really pretty obvious, even to somebody that's not particularly familiar with arthroscopy. But if you can debride that tissue with an abrader, then again, these patients generally are very happy. And that's arthrofibrosis in the joint. You can get bony impingement as well as soft tissue impingement. Again, this can be at the front, it can be at the back, the so-called os trigonum syndrome. And again, it's not too surprising when you look at that CT scan that this is symptomatic. Again, you can see there your burr removing the bony spur. And again, this can be done minimally invasively, and the patients are very happy. Generally, I say they can get back to an office-bound job after about 2 weeks, maybe up to 6 weeks for a manual worker. What about nerve damage? Well, this is something that we do see around the ankle. The one that is most commonly injured is the superior peroneal nerve, and that will often present with a burning dysthesia over the top of the foot. They may complain of pins and needles. There'll often be a Tinel's sign just where it perforates the deep fascia, and that's about 8 centimeters above the tip of the lateral malleolus. And if you percuss in that area, it is often quite symptomatic. You can make the diagnosis with a local anesthetic injection along the course of the superior peroneal nerve, and sometimes releasing that nerve from the entrapment can be a very effective treatment. But it's not just that can be a problem. It can be a neuritis, it can be a developing neuropathy if they're diabetic, and obviously chronic regional pain syndrome. Don't forget about congenital abnormalities. The ones that are associated with ankle sprains are your talar coalitions. Again, if you don't look for them, you won't find them. They can be fibrous or they can be bony. Calcaneonavicular ones respond quite well to resections. The talocalcaneal ones are a lot harder to treat, and I've got to say that in general I find these quite a difficult, challenging problem. Resection doesn't work particularly well, and they often end up doing selective fusions. What about functional instability? Well, 20% of people will complain of that. This is a subjective feeling of giving way rather than true mechanical instability, and the commonest cause for that is weakness of the peroneal muscles. If you get them to dorsiflex and evert against resistance, if you can overcome that movement, then they are weak muscles. So if you can push their foot down into plantar flexion and inversion, they need physiotherapy. And most of them will respond to physio, but if they have ongoing pain, that may be interfering with their ability to rehab, and therefore an arthroscopy may be a useful treatment modality. Get rid of their pain, they can then rehab properly. Obviously, gold standard for instability is the rostrum ligament reconstruction, and that will be covered elsewhere. Suffice to say that we can do it through very small incisions these days, and it's a very effective treatment with about 95% successful results. Okay. So in conclusion, it's a very common complaint to have. I think the most appropriate thing is a careful history and a careful examination, and that will direct your investigations appropriately. But if you can accurately identify what the problem is, a lot of these problems will respond very well to treatment.